Hello, everybody. Good morning and good evening to you all. How are you all doing? Okay, great. I'm doing great. I'm good. And how's your preparation going? How's your prep? Is it progressing well? Have you already taken your date for the exam? Anyone here who has already taken the date for the exam? Okay, Harsha says not yet. Elmarie says not yet, but plan for 2019. And Natasha says planning for March. Okay, so here's what I want you to do. Decide on a date, okay, and just set it in stone, because that's the only way you can make sure that you actually, stay consistent with your preparation and you actually go and take the exam. Okay. Now I've seen quite a lot of people who decide on, getting CPHQ certified, but they never quite get to that stage of blocking their exam date or scheduling their exam window. And because of that, what happens is they never feel quite prepared. And so they keep procrastinating and keep postponing their CPHQ plans. I know a few people who've actually put off CPHQ that way or procrastinated on their CPHQ for about 2 or 3 years that way. So and you all are probably already familiar with the law of diminishing intention, right? Diminishing intent, where because you keep on procrastinating it, your desire to get CPHQ or your inclination to get CPHQ will go on waning as time passes. So you don't want that to happen to you. So just make sure that you schedule your exam and go right through it. Remember what I told you before. You are never going to feel 100% ready for the exam. That never happens. It has never happened with anybody. So, but that's fine. Okay, it's what is important is that you are just ready enough to go and take a crack at the exam, and you will do fine. Okay, that's generally been the experience with everybody. I know Sadia here is taking the exam on 13th of this month. um, Good going, Sadia. I hope your preparation is progressing well. um, just before we get started, just to inform you, I had sent out an email after our first webinar, and I had sent you a link. That is where all the webinar recordings and the slides from the webinar are uploaded. So that's an ongoing link. That is what you that is where you can get all your materials. Okay, so I just don't want to bombard too many emails on you. That's why I'm not going to keep sending you email saying here's the link, but just retain that link for your use. Yeah. Okay. So with that, let us get started. Okay, and let me just make sure I share the screen. Oops. Okay, just give me a second here. Okay, so we are um, on our third module, which is performance and process improvement. Now, in this, you can expect about 40 real questions and 5 research questions. And the bulk of those questions will be application questions. You get around 26 application questions, which in my experience are generally, common sense questions. So if you just go over all the materials that I'm providing you, you should be all set. You should be able to score well on this. And Then you have about nine questions which are analysis and 10 questions which are recall type questions. Again, if you go through the content that I'm providing here, you should do well with the recall questions as well. Remember, the recall questions across all these four themes are really your low hanging fruit, right? There is really no reason for you to not score on these recall type questions. Okay, so what are some of the important concepts in this module? You can definitely expect some questions on teams, various approaches to process improvement. There will be some discussion and questions about quality tools and techniques, about how to plan and implement process improvement initiatives, some bits about clinical guidelines, monitoring and evaluation of clinical processes, which we'll be talking about later, the concept and theory behind organizational learning and training, and also what incentives can be provided to staff for advancing quality. Okay. Again, a quick recap of where we are with our webinars. So bulk of the content is in the 2015 content outline, and the remaining portion is what we cover on this webinar. Okay. So what are we going to cover in this particular webinar? We're going to cover any new concepts or materials according to the updated outline. We're going to reinforce the most essential content, understand the role of healthcare quality professionals, and learn what kind of questions can be asked pertaining to each subtopic that we are going to cover here. Okay. And a remaining review of the CPAs of the rest of the topics are provided on the CPHQ Essentials course. Okay. Okay, so again, some ground rules. You will be in mute mode. Please feel free to type in your questions and comments. Okay, let's get started. First, I want to talk to you about the evolution of healthcare quality. These are a few names that you should be aware of, and what was their main contribution to the field of healthcare quality. So Walter Shewhart was in many ways, you could consider him as the father of quality. He was a statistician with Bell Labs, and he is the person behind the Shewhart cycle, or what we know as the Plan, Do, Check, Act cycle, which later on became the Plan, Do, Study, Act cycle, which was later, Edwards Deming was the person who then adapted it into the Plan, Do, Study, Act cycle. And Walter Shewhart is also the person who gave us the concept of statistical quality control or statistical process control. And so what did Edwards Deming do? Edwards Deming basically was invited by the Japanese after World War II to help them repair their economy. And he basically helped rebuild Japan, and he gave his philosophy of quality to the Japanese. And Deming gave a few key concepts to think about. He said that 85% of the problems that you find in an organization are usually process or system related, and only about 15% are traceable to individuals. Okay. Now our inclination is usually the opposite. Whenever something goes wrong, we want to pinpoint it to some person, and we want to blame somebody for it. We don't think that it's a problem in the system. The system is what causes people to make mistakes. And so Deming gave his 14 points, a 14-point management philosophy. Okay. And you could actually look that up online. It's not important to our discussion here, but that's Deming's contribution. Then you had Joseph Juran, who gave the concept of the quality trilogy. Okay, now, what is the quality trilogy? It's quality planning, quality control, and quality improvement. Okay, so it all begins with quality planning. You decide what your aim is, what your mission and vision is, and what you need to put together a plan for quality. Then you go into the domain of quality control, where you are reducing variation, and you're trying to bring down the variation and make the process more predictable. And then you move on to quality improvement. Once you have things under control, then you try to slowly improve your processes. And from there, you again go back. It's like a cycle. So you again go back into the process of quality planning, because from the lessons from your quality improvement should feed the next phase of your quality plan. Philip Crosby gave the concept of zero defects. He basically said that quality it is usually less costly to create good quality. Okay, so he said that poor quality is actually more costly. Okay, and he also said that organizations generally go through different stages of maturity as they're trying to build their quality. Okay, there are times when the first stage is when organizations are clueless about why they have quality problems. Okay, so that is the phase of uncertainty. From then on, they move to the phase of awakening, where they start knowing why they have quality problems. Then they go into enlightenment and wisdom, where they get more awareness, and finally they reach the state of certainty, where they are able to say that we know why we don't have quality problems. Okay, so Philip Crosby is also credited with the concept of zero defects planning. Okay, just remember that. Remember that. I mean, these could all be recall questions on your exam. That's why you need to know them. Okay. All right. So let me just give me a second here. Okay. Now, then we come to Kaoru Ishikawa. Ishikawa is also one of the main names, along with Walter Shewhart and Edwards Deming. Ishikawa is the person behind the cause and effect diagram, or the fishbone diagram. You may recall from our previous discussions, and he is also credited with giving us the concept of total quality control. Okay, so which basically means that quality has to be a function for every single department in the organization. Okay, so it's him, Juran and Deming, who have contributed to the development of the concept of total quality management. Okay, now healthcare quality. Okay, this was quality. The previous slide was about quality in general, but now we come to healthcare quality, and healthcare quality went through several different eras. The first era was mainly about Florence Nightingale, who was in many respects the first person who used data to demonstrate about the quality of care. Okay, this goes back to the Crimean War and stuff like that, and she traced the mortality of soldiers in the Crimean War, etc. We don't have the time to go into all those details, but just remember that she is the person who started using data to demonstrate about clinical outcomes. And then Codman actually advocated, he was a surgeon in Boston, and he advocated that you need to, once you provide care to the patient, you need to trace that patient over a period of time to see if whatever you did to the patient in terms of clinical care actually made a difference and created better outcomes for the patient. Okay, and because of his work, the American College of Surgeons established like minimum standards and hospital standardization program. So basically, Codman was, you can call him the father of clinical outcomes. Okay, he was a person who said that whatever you do to the patient should be traced back to the clinical outcomes that you create. Then the second era was about Don Obedian. So Don Obedian was the person who gave us the structure, process, outcome framework. Okay, he said if you want a certain kind of outcomes, you will have to follow certain kinds of processes. So if you want to improve outcomes, you have to improve the processes that you carry out, and those processes in turn can be traced back to the structures that you have in place. So structures would mean the staff, their qualifications, their competencies, the physical equipments, all of those. Okay, so Don Obedian gave the structure, process, outcome framework. And then Joint Commission also in the 1950s and the 60s, Joint Commission became more and more visible, and the Joint Commission started conducting audits. They started setting some accreditation standards, and that started to be tied to the quality movement. Okay, the third era was is mainly attributed to Dr. Donald Berwick, to Paul Batalden, and Brent James. Okay, now Dr. Donald Berwick is the founder of the Institute for Healthcare Improvement, and these three pioneers basically brought several concepts from manufacturing and from other industries into healthcare. Okay, so that is their main contribution. And Berwick actually was he was part of the Obama administration, and he is largely credited with the concept of the triple aim. We've discussed triple aim in our previous module as well, which is improving patient experience, improving population health, reducing healthcare costs, etc. And he has contributed a lot to the Affordable Care Act as well. Okay, so these three pioneers were basically important were actually, the people behind bringing several concepts from other industries into healthcare and creating a movement in healthcare quality improvement. And the fourth era, which we are in currently, is all about patient advocacy, engagement, and activation. So rather than considering a patient as someone that you do something to, you put the patient at the center of care and create the clinical experience around the preferences of the patient. Okay, so this goes to having an ombudsman or a patient advocate in your organization who will manage complaints, who will collect the inputs from the patients, etc. Having a patient bill of rights, those kind of things. So that's the fourth era of quality. Okay. Now, let's talk about having a performance improvement plan. Okay, there should be every organization, every healthcare organization must have an organization-wide plan and a service level plan. Okay, so there is that huge broad level plan as well as a plan for every single department. And what should that service level plan include? You must identify your population served. You must describe what sort of services are provided to the patient. You must make sure that your priorities there and your aims there are aligned with the organization's plans and strategies. You identify the requirements, and where do you get these requirements from? You get it from the feedback from the patients, from the community, from regulatory requirements, all of those. You select appropriate metrics so that you can measure. Again, we have talked about all this in our previous module. You develop a monitoring plan and an evaluation plan, and then you identify methods for improvement. Okay, so this is how a plan should be written up. Again, this is a role of the healthcare quality professional. Many of these functions are what healthcare quality professionals actually do in the organization. Now, how do you set your process improvement priorities? Again, make sure that it is aligned with your strategic direction first. Secondly, you should use some criteria. What sort of criteria? You are basically trying to work on clinical processes that are high risk, that are high volume, that are prone to problems, have a direct impact on patient safety. It'll help you to save cost or make it more cost effective. You should look at things that are high priority in terms of customer satisfaction, or it could be any other criteria depending on your organizational priority. Okay, and when you're doing this, when you're trying to set these priorities, you use certain improvement tools such as a prioritization matrix, which we'll be talking about going forward. Okay, I'm just gonna go back and forth because I'm having some technical issues with my laptop here, so I'm sometimes not able to see the questions that that you're all questions or comments that are coming from you guys. So I'm just gonna sometimes exit the presentation and just take a look at your questions. So bear with me if there is some delay in answering your questions. I am facing some technical challenges today. Okay, so now, what are some key steps when you're implementing process improvement efforts in your organization? Again, this is the job of the healthcare quality professional. You can definitely expect a question on this on your exam. Process improvement, performance improvement, and the role of healthcare quality professionals is a favorite question on the CPHQ. So definitely you should be aware of this. Again, it is very common sense. There is no rocket science here. So you should be able to answer it. So what are the key steps? First, you have to ensure leadership support, assess your priority and feasibility related to your organization's strategic plan and strategic priorities. Identify a specific aim and set a specific aim. You convene an interdisciplinary team involving physicians, nurses, allied health quality champions, data scientists, all of them. Use QI tools and techniques. We have discussed many of them in our previous module, and we'll be discussing some in this module. You develop the change idea. You identify your measures. Remember, you identify your outcome measures, you identify process measures, and some balancing measures. Okay, then you go about educating your staff. Then you implement and test the change. Remember, we are not saying go ahead and do the change. You're saying test the change on a small scale. Then you collect, analyze, and evaluate the data. Based on whatever you learn from evaluating the data, you make additional changes. Okay, or you might want to even expand those changes. You report and display those results, make sure that all the stakeholders are aware of your results. Then you continue to monitor your performance, and then you compare your performance either internally with other services in your organization, or you may compare it externally with other organizations in your region or in the country, and then you celebrate your successes. So these are the key steps to implementing your process improvement. You could get you can think of a bunch of questions that you could get from this one slide. Okay, how do you execute your process improvement efforts? Okay, this is a three-part model, okay, for executing, and this again comes from the work of the IHI. So basically it's about achieving your strategic goals. Now, when you're working on process improvement, right, you have this threefold aim. One is achieve the strategic goals of the organization. Second is to manage your local improvement, which means at the service level. Okay, and the third one is to build capability in your organization so that through this effort, going forward, you can have several other improvement initiatives for which your people are fully equipped. Okay, and to do that, you need to provide leaders at several different levels. You need to provide day-to-day leadership in your clinical microsystems. Okay, and then you need to have some ideas about how you're going to spread and sustain these improvement efforts. Okay. All right. Now let's talk about evidence-based practice guidelines, about clinical guidelines. Now we've already discussed about the difference between evidence-based medicine and evidence-based practice in our previous module, so I'm not going to talk about that now. Now, why is evidence-based practice guidelines important? Or why is evidence-based practice important? Because it promotes patient safety by reducing the variation of clinical care provided by different clinical providers, and it also avoids unnecessary interventions. Okay, now let's talk about evidence-based quality management then. What is that? So evidence-based practice is mainly about the clinical service that you provide, but evidence-based quality management has two components. Okay, one is the outcome of your clinical care, and the second is the outcomes from your from your system at a system level. Okay, so the clinical outcomes will come from any clinical research data that you can get, or the stuff from literature that you can get. And then the health services research involves all kinds of system level things about health policy, health management, public health related research. All of those are health services research, so that will help you improve things at a system level. Okay, now when you're looking at guidelines, it's important to look at the rating of the evidence for each guideline that you're looking at. Whenever you look at a piece of literature, right, it's important to look at the rating of the evidence, and this rating is provided by the United States Preventive Services Task Force. Okay, and the USPSTF actually has levels of evidence and grading system. Okay, what are the levels of certainty? There is a high, moderate, and low level of certainty. That is given by the USPSTF. What is high level of certainty? That means there is a vast amount of literature about a particular intervention or about a particular service, and it shows that consistently the evidence produced is consistent. Okay, and so you can go ahead and safely assume or actually safely infer that this particular thing creates a benefit. Okay, this particular evidence creates a benefit. Okay, and so on. So that's how high, moderate, and low goes. Okay, and then the USPSTF also has grades for different levels of clinical services. So let's say you're looking at the evidence base for providing a particular drug, okay, in a clinical condition. Or providing a set of clinical interventions for a clinical condition. Okay, so you have different grades for that. So you have A, B, C, D, I. When you say A, basically it means that that service is recommended and it has been found to be highly beneficial. B would mean that it is recommended and there is a moderate level of certainty that this particular service is beneficial. C would mean that the evidence is sort of 50-50, and so you might want to take it with a pinch of salt. D would mean that the USPSTF actually recommends against providing that sort of service. Okay, either it does not have any benefit or maybe it causes some harm. And I basically means that the evidence is inconclusive. Right, so these are the gradings for different kinds of clinical guidelines or for any quality management guidelines given by the USPSTF. So you could get a question, sometimes you get a question on these kind of guidelines, and it is pretty straightforward to understand. Okay, now where do you get all these evidence-based practice guidelines? Again, we have spoken about this in our previous module from several sources: IHRQ, Leapfrog, National Quality Forum, etc. Okay. Okay, is my audio okay with you all? Yeah, all right. Okay, so we've talked about evidence-based practice guidelines. Again, what is the role of the healthcare quality professional here? Your job, you may be required to look at the literature, find evidence-based practice guidelines, advise your leaders about these evidence-based practice guidelines, do some research about the level of certainty or about the grades of the evidence. Right. So the question that you get on the CPHQ, maybe, they might give you a small scenario about a certain clinical condition and say that the evidence suggests that the level of certainty is moderate and it's a grade B, a grade B by the USPSTF. So what would you advise as a healthcare quality professional? What would you advise your leadership? And then they'll give you 4 options. Right. So I've already explained what these grades mean. Based on that, you just make a logical decision. Okay, so that's one example of a kind of question you could expect. Okay, now let's talk about clinical guidelines, pathways, and bundles. There is a small distinction between guidelines and pathways. Okay, sometimes people use them interchangeably, but there is a minor distinction. What is that? Guidelines are defined as consensus statements which are developed to assist in clinical management decisions. Okay, so after a review of a large amount of literature, you come up with some statements about how best a particular clinical condition can be managed. Okay, and one of the main publicly available databases of these guidelines is the National Guideline Clearinghouse. Okay, National Guideline Clearinghouse. Just remember that name. Now, how is that different from pathways? Okay, now pathways are basically algorithms. Okay, and those pathways are algorithms or tools that are developed to manage quality outcomes of cost of care based on these guidelines and evidence. So what you will do is, based on the statements that are made in the guidelines, you can develop a pathway that suits your organization. Okay, and in effect, what it helps you to do is the pathway actually helps you to implement the evidence from the guidelines into the daily practice of clinical care. Okay, and pathways are generally meant for the ideal uncomplicated patient. Okay, the complex cases may not fit. So this is where there is this source of tension in clinical care, if you are familiar with it. So what happens is, some physicians or nurses actually give some pushback against implementation of certain clinical guidelines and pathways, saying, oh, you know what, my patients are sicker, my patients are special, they don't fit into this pathway. That is fine, because pathways are generally meant to do the greatest good for the greatest number of patients. Okay, so whenever you develop a pathway or a guideline, you keep in mind these uncomplicated kind of cases. Okay, and so that is why it is found that pathways are generally easier to develop and easier to implement in surgical care. Why? Because the process of care goes in a set pattern, right? You know how you're going to do the surgery, and then finally the outcome is also something that is very definite, versus the medical conditions which have multiple different factors that could affect the process of care as well as the outcome of care. Okay, so surgical care is more conducive than medical conditions. Okay, now what are the benefits of having clinical pathways? It shapes the outcomes of care. It provides timelines for interventions. It supports clinical management, resource management for your organization, financial management, and it also helps with audit management. Okay, just keep an example in mind. Let's say I come to your hospital for a hand surgery. Okay, if you have a clinical pathway for a hand surgery and you follow that pathway in giving me the treatment or walking me through the surgery, then think about all these different benefits that will create. Okay, it reduces the variation in care. So depending on whether it could be regardless of whether it's surgeon A or surgeon B who's going to operate on me, I know that a particular standard process of care will be given to me. The cost can be managed and decreased. It empowers the patient because then you can inform the patient about what is expected from the care, how long it will take to heal, how long will it take for me to get full function of my hand, that sort of thing. It facilitates the development of standardized physician order sets, interventions, and documentation, and it reduces in-hospital complications, length of stay, and it also leads to improved documentation because there is standardization. So the gist is that clinical pathways help in creating standardization. It reduces variation of care, okay, between different providers, and so because of that standardization, a lot of benefits ensue, such as reduction in cost, reduction in variation, improving documentation, etc. Okay, now which situations do you use clinical pathways for? It is generally better, or it is generally easier to develop clinical pathways whenever there is a prevalent pathology, okay, such as, for example, pain management in your clinical setting. Okay, it's easier to develop a clinical pathway for pain management. The pathology involves significant risk. It's a high cost clinical condition. There is a well-defined pathology for the clinical condition. Again, that's why surgical cases are more amenable to clinical pathways. There is a predictable clinical course. There is a possibility of obtaining professional agreement. That means different providers of care will agree on a minimum clinical care plan for this particular condition. There is a well-developed body of literature with recommendations for how this care has to be managed. Okay, so it's not like some new condition where not much literature exists, and so there is a lot of controversy about um, which sort of clinical interventions must be utilized, etc. That's not the case in these conditions. Okay, so there is an existence of recommendations. It involves multidisciplinary implementation, right? And there are relatively mature guidelines for these clinical conditions. So, for example, you could think of like cardiovascular conditions, or stroke, or asthma, or diabetes, etc. Right? So all of these have very mature guidelines. There is a huge amount of research and literature that could provide the guidance about how to care for a patient. Okay, now let's talk about the concept of bundles. Again, the IHI has done a lot of work on bundles. Now, what are these bundles? It's a small set of evidence-based interventions for a defined patient segment or a population. It should say defined. There's a typo there. A patient segment or a population and care setting that, when implemented together, result in significant better outcomes than when implemented individually. So in effect, what it means is, when you have a certain clinical condition, there is a bunch of things that you can do, okay, 3 to 5 interventions generally, that when applied together will result in significant improvements. So the key here is that they have to be applied together, and they are ineffective when applied individually. Okay, they may not create the same results when applied individually. So what are some guidelines for designing bundles? Usually it consists of 3 to 5 interventions. They are relatively independent elements. That means one does not depend on another. It's used with a defined population in one location. It's developed by and implemented by multidisciplinary care teams, and it allows for local customization and use of clinical judgment. So some of the most commonly known, widely used bundles are related to ventilator-associated pneumonia, central line associated bloodstream infections, sepsis, perinatal care. Okay, and the reliability of the bundle is usually ensured via an all or none measurement, which means, again, these bundles have to implement it. Their effectiveness is dependent on them being implemented together as one. Okay, anyone here who's familiar with bundles, who has worked with bundles? No? Okay. So, one example that I can give, Harsha says yes, Sadia says yes. Yeah. So, an example that I can give is central line associated infections, bloodstream infections, right? It can be used in the intensive care unit. So you have different, like, you have bundles about improving skin care, the skin antisepsis, the site that you use for insertion of the line, then daily review of the need for the need for the central line, right? So those are examples of a bundle. Okay. Then you have sepsis. You have the sepsis 6 bundle, right? So antibiotics, fluids, blood cultures, all of those, when they're done together, they create benefit for the patient. Okay. Yeah. So May says I've worked on bundles. Um, okay, just hold on. Okay. Able to hear me okay? Okay. So the question is, what does it mean by customization of bundles? What type of changes could be done? Okay. So generally, Sarah, what it means is it's not, I mean, you can make minor, like very minor changes to how those bundles are implemented. For example, the checklist that you may develop for implementation of your bundle, right? And who does what, when it is done, those kind of minor customizations can be made to the bundle depending on your healthcare system, because depending on the resources that you have available, and also depending on the population that you're working with. For example, the bundle will be customized. For example, the sepsis 6 bundle, it will be customized based on whether you are applying it to the adult population or to the pediatric population. And even within the pediatric population, how you apply it to a general pediatric ward may be different from how you apply to a pediatric emergency or an ICU, etc. Okay, you get that, right? So, and Harsha says we're using CLAPSI, WAP, and sepsis bundles. So remember, the key thing to remember about bundles is the all or none phenomenon. Bundles work, bundles are effective when you apply them as one. Okay, so that's the key thing to remember here. Okay, and one good resource that I would point out is, if you go to the IHI website, right, you will find some implementation plans for bundles. Okay, anyone familiar with that? Have you used that? Have you seen that? So I would really encourage you to go and take a look at, go on the IHI website. It's free. You can, if you just log in, you create a login ID, and then you can download those how-to bundles. Okay, how-to implementation plans for these bundles, like for WAP, for CLAPSI, etc. Right? That's Yeah, so that's it's a very helpful tool. I have myself used it in several different settings, for some improvement projects that I have done, and also when I was coaching some other teams on how to implement them. Right, it's a wonderful resource. So Natasha says familiar with the literature on IHI. That's great. Okay, now what are some approaches to process improvement? Okay, quickly, 3 concepts: retrospective audits, quality assurance, and re-engineering and system redesign. You just need to be familiar with what these terms mean. That's all. You don't need to get into the details of these. So retrospective audits are basically whenever you have a closed file after the patient is discharged, you go into the file and you look at certain elements of clinical care to make sure if those elements are being fulfilled or not. Okay, so did you do those, whatever the literature suggested must be done for this particular patient, has it been done or not? Okay, so those are the retrospective audits, and that's basically something similar to what we do for Joint Commission as well. Okay, then you have the concept of quality assurance. So in addition to audits, it's also important that you use the data from the audits to identify problems in your clinical care at the system level. Okay, and this monitoring and fixing of these problems must go on an ongoing basis. Okay, so that is the concept of quality assurance. Okay, so you conduct those audits, you gather the data, you monitor how you're performing, and go on doing that process. So that is quality assurance. Then in the 90s, there was this concept of re-engineering and system redesign. This was actually fed by this whole mergers and acquisitions and development of these big monopolistic healthcare systems in the United States. So decision makers were looking at how to make systems more efficient, how to reduce redundancies, how to save cost and all that. So that's where they started to redesign a lot of systems, and they were thinking about how to re-engineer these big these systems that were created out of the mergers, right? But what it did was, because of this, it created a lot of discord among the staff, right? Because people were losing their jobs. Just cost, because cost was a main priority. There can be downsizing, there can be layoffs, all of that, which led to declining morale of the staff. And so that's why re-engineering and system redesign actually fell out of favor. Okay, what are the current methods that are used for process improvement? Three main ideas. You have rapid cycle improvement, which is, again, if you look at the work of the IHI, it's all about, mainly about rapid cycle improvement, and it's based on a collaborative approach, even within your organization as well as outside the organization. Okay, so you bring about a lot of partners to work on it. You use evidence-based practice methods, and you develop some systems for implementing processes of improvement. Okay, and the key concept here is the use of the PDSA cycles and what's known as the IHI model for improvement, and we'll be looking at it in one of the other slides that are coming up. Okay, so remember, IHI model for improvement and PDSA cycles. The key concept here is of spread. So once you have perfected a change idea in one particular area, you then have to use that idea and spread it out into different levels of your organization. Okay, and when you go into different levels of your organization, it will also require customization. So it's not like you have done something in one particular area and you can just take it and apply it verbatim in some other area. That does not happen, right? So that's the concept of spread. Then we have discussed briefly about Six Sigma in our previous module. It's all about eliminating errors and variation. Okay, so Six Sigma is about eliminating errors and variation. The concept is that you use the right metrics, you use statistical methods, and the process is very data driven and customer focused. Okay, so reducing variation. Right. Okay. Then you also have the concept of lean. And lean is all about reducing waste. Okay, the idea is that you do only value added stuff for your patients or your customer, and you reduce waste as much as possible. Okay, and value is always defined from the customer's perspective. Whatever the customer values, or whatever the customer considers as value, is what is true value. Okay, and there are 5 basic principles in every lean enterprise. First is you specify value from the customer's perspective. Then you identify all the steps in the process from start to end that the customer has to go through, or that the organization goes through in providing a service to the customer, and you remove all non-value added steps and waste steps. Okay, make sure that value flows to the customer smoothly. You implement a pull system instead of a push system. Okay, that helps to reduce waste. And then you go back, you follow the system, and you go back to the first steps. So remember the key words for each of these concepts: rapid cycle improvement, collaborative approach and PDSA, and IHI model for improvement. Six Sigma, eliminating errors, and lean is about reducing waste. Okay, now let's come to performance monitoring and evaluation of clinical processes. Okay, whenever you are considering a particular clinical process for audits, there are some criteria, okay, for conducting those audits. What are those criteria? Was the intervention used in the manner it was intended to be used? Was it performed properly? Was it performed safely? Was there any adverse effect? Okay, were the staff who performed this particular clinical intervention competent enough to perform it? Was the care provided effective? And was there a better way of doing it, or was there a better alternative to the intervention? Okay, so when you're doing an audit on a particular clinical care that was provided to a patient, okay, these are the questions that you should ask. Or when you, let's say you have identified a quality or patient safety issue as a result of the audits that you've done, these are some questions that you should keep in mind. Okay, and what are these performance monitoring and audits generally done for? Remember, as we discussed previously, it's usually done for high risk processes. It's done for processes that have a high degree of patient safety issues attached to them, right? So anything that is risky, anything that affects patient safety, those are the kind of issues that you will be monitoring. So again, what could those be? Examples are medication use, right? When you have high risk medications like antibiotics, opioids, anticoagulants, or chemotherapy medications, etc., right? You could use those questions for medication use monitoring as well, right? Was the correct intervention used? Was it performed properly? Was it performed safely? Were there any adverse effects to the medication? Were the staff competent in delivering the medication and in administering it? Was it effective for the purpose for which it was intended? And was there a better alternative that could have been provided to the patient? Then you could apply those same questions to blood and blood products use, to the use of restraints, okay, for operative and invasive procedures, for cardiopulmonary resuscitation, for morbidity and mortality investigations, and infection prevention, surveillance, and control. Okay. Now, a thing about restraints. Restraints are no longer allowed in the long-term care setting. Okay, just remember that. But they can be used sparingly in acute hospitals. Okay, for medical surgical populations, and for if there are any behavioral health issues, and they can also be used in the emergency department for unpredictable patients and unpredictable situations. So just remember that. And what else? Okay, so that's about performance monitoring and evaluation, and about conducting audits on high risk patient safety clinical care processes. Okay, now let's talk briefly about medical peer review. What is this concept of medical peer review? Okay, it is the evaluation of an episode of care conducted to improve the quality of patient care or for the use of healthcare resources. Right. So basically, let's say there are two physicians, and so one physician will be conducting a review of a clinical care that was provided by the other physician. And so you'll go into the charts and you'll review the entire care process, and you will see if the adequate kind of care was provided, how were the healthcare resources used, etc. And then that is used as a learning for improving the quality of patient care. This is a process that is protected by statute. And how do you define a peer? Important to remember this definition, because there can be some tricky questions on the CPHQ on this concept. So a peer is a healthcare professional with comparable education, training, experience, licensure, or similar clinical privileges or scope of practice. So my question to you, can a peer review be conducted on a physician by a nurse, by a very experienced nurse? It cannot be conducted. Okay. Can a peer review be conducted for a pediatric consultant by a surgery consultant? No, it cannot be conducted. Right. So you get the gist. Okay. And this process is managed by a peer review committee, which is a subcommittee of the medical executive committee in the organization. Okay. What are some elements of effective peer review process? Basically, it should be consistent. That means there should be some defined processes for conducting it, documented procedures for conducting it. Okay. It should be defensible. That means it should have a logical sequence to it. There should be a balance. So there, all minority opinions and minority opinions must also be considered. This is a process that is considered in reappointment of physicians and for renewal of physician privileges. It must be tracked over a period of time. And if there are any actions that come out of the peer review process, there should be an action tracker. That means it must be monitored for effectiveness going forward. It should be communicated adequately to whoever needs to know the results. And there must be some implementation of recommendations. Again, this goes back to the idea of having action trackers. Okay, so these are the elements of an effective peer review process. Again, you could have a straightforward application or recall question on this particular aspect of the peer review process. Okay. Okay, how are we doing so far? We're now going to switch to talking about tools on quality improvement. Everyone okay? All right. All right. So let's go right ahead and talk about performance improvement tools. So I think I have mentioned this previously to you. When you talk about quality improvement, there are three kinds of tools. Okay, you have problem identification tools, you have problem analysis tools, and you have problem solving tools. Okay, so these are the three main kinds of tools that you have in quality improvement. Okay, now problem identification tools would be, remember we talked about check sheets in our first webinar, right? That is a problem identification tool because the check sheet is used to identify the problem. Then you have problem analysis tools. So the cause and effect diagram is an example of a problem analysis tool. All right. Then you have problem solving tools, and we will be talking about problem solving tools in the latter part of this particular webinar. So just keep that in mind. You need to have that picture in your mind about the three kinds of quality tools and performance improvement. Okay. Now, let's quickly run through some performance improvement tools. The first one is a cause and effect diagram. We've already spoken at length about cause and effect diagrams in our first webinar, so I'm not going to revisit it. You have a checklist. Okay, a checklist is a very useful tool, which is basically actually a problem solving tool also. Okay, it's basically a way to ensure that all the required steps in a particular process get completed. Okay, for any particular thing that needs to be done. So you have different kinds of checklists. If you're working in the healthcare setting, I'm sure you're aware of it. You have anesthesia checklists that are used in the operating room. You have surgical safety checklists which are used in the operating room, right? You also can have checklists for those bundles which we talked about, like for central line bundles, etc. What a checklist does is basically it takes the scope of human error out of the equation. Right, so checklist, as you know, this is one intervention that has come from the aviation industry into healthcare, because pilots, no matter how experienced they are, they use a checklist before the flight takes off and after the flight lands. Right, so checklist is a very useful tool for safety and to ensure that all the critical tasks that must be done for any particular process gets completed. Then you have brainstorming. Now, brainstorming is a tool that is used whenever you want to come up with a large number of ideas, whenever you want to generate ideas. Okay. Now, the fruits of the brainstorming, so to speak, or the results of the brainstorming may be plotted on your cause and effect diagram. Okay. For example, let's say you're trying to find out all the reasons for increased waiting time in a clinic. Okay. You identify all the different reasons, and then you can plot them on your cause and effect diagram. Then you have what's known as a nominal group technique. Now, nominal group technique is somewhat similar, I would say, to the brainstorming technique. Okay. Now, nominal group technique is generally used when the team members who are working on a particular project are not familiar with each other. Okay. And so what everybody will do is everyone will sit in silence and note down their ideas. Yeah, So everyone will note down their ideas, and let's say if somebody is working, or we as a group, okay, all the people on this webinar, we as a group are working on a controversial topic. So everyone has very strong opinions about that particular issue. Then it might be better not to have everybody shout out their opinions, but it might be better to give them to use the nominal group technique, where we are all working in silence. We get a bunch of index cards and we note down our ideas on those index cards, and then a facilitator will collect all those cards together. And you can also rank order your opinions based on how important you consider them to be, and the ones that get the maximum number of votes would be our priority. Okay, so that is the concept of the nominal group technique. Okay, multi-voting is also another tool. Again, so what we are doing is, let's say we come up with a bunch of ideas as a result of our brainstorming. Okay, then what we do is we ask the members of the team to go and vote for their ideas. So for example, let's say we come up with 10 ideas, okay, about how to solve a problem. And then what you will do is you ask each person to get up and say, okay, if you had to vote for only 3 ideas, which ones would you vote for? And everyone goes and does them, right? Everyone goes and puts their votes against these ideas. And then what you do is you count the votes against each idea, and the ones that have got the maximum number of votes would be chosen as your as the winning ideas, so to speak. Okay, so that's the concept of multi-voting. So basically it helps you to prioritize and narrow down your options and agree on something to work on. That's the concept of multi-voting. Okay. All right, and then you have what's known as a Delphi method. So Delphi method is actually a combination of brainstorming, nominal group technique, and multi-voting. Okay, this happens when your team members are disposed. Let's say they are not in the same geographical location, and you want to do the same kind of work, right? You want to generate a lot of ideas, and you want to narrow down and come and agree on a few ideas to work on. You could do that through emails. Okay, so let's say one person will kickstart the process of brainstorming, collect all those ideas together, and then you send it out to the group to multi-vote on those ideas, or to prioritize their ideas, and then it goes to the next person. That next person will actually narrow down the list of ideas, and so on. That's the Delphi method. Okay, it's pretty straightforward. Then you have what's known as the voice of the customer. Again, this has come from the other industries into healthcare. What this means is it's a very specific way of translating very fuzzy ideas or amorphous statements from patients into something tangible. Okay, so for example, let me give you a very simple example. Let's say I conduct a patient satisfaction survey for patients who come to my clinic. Okay, and one of the comments, let's say one of the predominant comments, frequently recurring comments, is that I wish the doctor would spend more time talking to me or listening to me. Okay, so a lot of patients are saying, I wish the doctor would spend more time listening to me. Now, how are you going to measure that, or how are you going to work on that process? Okay, what you could do is, so that is the voice of the customer. The customer is saying he wants to be listened to more, or she wants to be listened to more. Okay, what I could do is I could translate that into something very specific. So for example, I can track the number of seconds that or the number of minutes that the physician stays silent and listens silently to what the patient is saying. This is something that I can track. You get the point? So that is the concept of the voice of the customer. Okay, so and then what you can do is you could have an improvement initiative on that particular project. So we can go on an ongoing basis every day in the clinic. You could take a sample of patients. You could look at the amount of time that the physician stays silent when the patient is explaining her condition, or you could look at the number of times the physician interrupts the patient in a minute. Okay, that could be another thing, and then you could try to go on improving that particular metric. Okay, so that is the concept of the voice of the customer. Okay, so Sarah is saying, are Delphi methods used with experts only? So that's a very good question, Sarah. So yes, it is easier to use. It's not that Delphi method is only used with experts. What it means is it works better when it is used with experts. Why? Because remember, these team members are not present physically in one single location. They don't have face-to-face interaction. Okay, so you have a group of people who are dispersed in several different areas, and the assumption is that these people are experts and they know the issue very well. And so, because their knowledge and their expertise allows them to work remotely on these issues. So yes, your point is taken. It's generally easier to use when you have experts in a particular process. Okay. Then Natasha is saying, can you please elaborate on the Delphi method? So does that answer your question as well, Natasha? Okay, so let me just go back. Okay, let's take an example. Um, okay, let's say um, okay, let's say there are there are I'm going to meet where I have three different hospitals in my community, and I want to improve surgical care in these three hospitals in my community. Okay, so I'm going to convene a meeting of the surgeons from these three hospitals, and I want to gather a bunch of ideas from them about how we can improve surgical care. Okay, now the thing is, we are not able to meet physically, and so probably we meet online, or we've been exchanging emails, etc., to try to work on the problem. So what I'll do is, as the facilitator, I will first say, okay, can you all contribute ideas? Let's all brainstorm, and can you all give ideas about how we can improve surgical care? So surgeons from location A will send their ideas, from the surgeons from location B will send their ideas, and surgeons from location C will send their ideas. What I will do is I will create one single document with all their ideas. Okay, then I will send it back to all those people, and I'll say, all right, now this is the bunch of ideas that you all came up with. Okay, why don't you rank order them, or why don't you give your votes to the top 5 ideas? So let's say there are 15 surgeons across these three locations. All of them give their votes to these 50 different ideas. Okay, everyone votes for five of their top choices, right? And what I can do is, then once these results come back to me, I will then rank order them based on the ones that got the highest votes, and then the second highest votes, third highest votes, etc. And I come up with 5 different ideas. Okay, so that would be, so what I've done is I've used the brainstorming and the multi-voting technique. Okay, and so now what I was able to do is, in spite of the fact that all of them were in three different locations and we have not met face to face, I was able to brainstorm, get a lot of ideas, and then rank order those ideas according to priority. Okay, so yes, so you're right. Yes, we are using a combination of these different techniques, and it works well because we are talking about improving surgical care, and these are surgeons we are talking about, so they have domain expertise to work on this particular effort. Okay, and okay, so then one more question that Natasha had is, how can you track the time the physician stays silent specifically? So, let's say as an improvement expert, or let's say because this is a clinic, there will be a nurse who will be standing with the physician, and the nurse could use a simple check sheet, and she could use a timer. Okay, these are things, believe me, I'm not just making this up. These are things that have been done already. Okay, there have been improvement efforts on these. So the nurse could stand there and time the physician to see like how much time the physicians, and there have been some studies as well. You would find it very interesting. They have found that physicians generally, I can't recollect the number of seconds, but there are some study that says that a physician will interrupt a patient in, like, I think, like 20 seconds or 30 seconds or something of that sort, right? Which is really less, which explains why patients don't feel heard, and obviously doctors are in a hurry because they want to see as many patients as possible, etc. Okay. um, Yeah, I can. So Natasha says, is there a paper you know of? Yeah, I can try to find out if there is a specific article. I know there is there was a study that was done on how many times patients get interrupted when they're narrating their clinical condition. I'll try to send that to you. Now, about nominal group technique, May has a question. Nominal group technique is very similar to brainstorming. Okay, in brainstorming, you gather a bunch of people in a room, and a facilitator will ask them to give their ideas. Okay, in a nominal group technique, what you do is you do that same exercise silently. So basically, people note down their ideas on maybe index cards or post-it notes. Okay, and why is that? Because let's say when it happens in two conditions. One, when you have a group of people who are not really a team, okay, that they are not a cohesive team, they have not been working together, and so they're relatively new to each other. Okay, so they may have some inhibitions about opening up. So that's why it's preferable that they work silently. The other one is, let's say you're working on a controversial topic where people have very strong opinions. So in that case, again, you would want it to be silent so that you don't create some controversy, or you don't create a heated discussion there. So nominal group technique is very similar to a brainstorming technique. Okay. Okay, now let's talk about affinity diagram. Affinity diagram could be a product that comes after your brainstorming. So what you've done is, after you have created a bunch of ideas, you can group them into themes. Okay, you could group them into themes, and you can organize the information that you've collected from your brainstorming. That's what an affinity diagram is used for. Then what is a deployment chart? It's basically a way of creating a project schedule, okay, for your different tasks. So what you will have is, you identify what is the first thing that needs to be done and what is the end point of that particular project, and you identify all the steps in between, and then you identify who's responsible for each step. Okay, you identify the owners, the process owners for each of those steps. Okay, it's basically a planning tool, and it's a project tool to ensure that work gets done. So it's called a deployment chart or a planning grid. Then you have a flow chart or a process map or a process flow chart. Okay, these are all interchangeable names, and it's one of the fundamental tools of quality improvement. Here you are going to graphically lay out the process from start to end. Whenever you are studying any particular process, you lay it out from start to end. You also identify the key areas or the key functions or the key people who are involved. So in this particular example, we are looking at the let's say the arrival of a patient, or the patient's journey through the ED. Okay, so from the time the patient arrives to the time the patient disposition happens, and you're looking at the key players or the key places that are involved. So you have the ancillary staff, you have the ED nurse and the ED physician. All right, so that's a process map. It helps you to visualize the entire patient journey. Okay, and then you could also do a value analysis on this particular step. I will talk about that when we talk about value stream mapping. Okay, so what the flow chart does is, it helps you to look at all the steps in the process. You can understand which ones are value added steps, and you can also look at if there are any waste steps in the process. Okay, and when you try to improve the process, what you could do is you could try to see if you can get rid of those waste steps and keep only the value added steps. Okay, also important to know is how many handoffs there are from one area to another. For example, when the patient goes from the ED nurse to the ED physician, or from the ancillary staff to the nurse, etc. Right? Remember, the more handoffs there are in a process, the more likelihood of errors. Okay, more handoffs, more errors. Remember that. Also, those diamond shapes that you see in the process, those are the decision steps. Okay, whenever decisions are made in the process, those are depicted by those diamond shapes. And again, the more diamonds or the more decision steps you have in a process, the more likelihood of errors and the more likelihood of delays in the process. Okay, just remember that. So that is the value of having a flow chart. Okay. All right, now let's talk about interrelationship diagrams. Okay, interrelationship diagrams, as the name suggests, it shows a relationship between different steps or between different areas in the healthcare system. in your area. Now, how do you interpret an interrelationship diagram? You must look at the number of arrows that come into one step or number of arrows that go out of a step. Okay, so the step that has the most number of arrows coming into it represents a bottleneck. Okay, it represents a bottleneck, and the step that has the maximum number of arrows going out of it is actually one of the critical steps. Okay, and whatever you do to that particular step can have a big impact on the rest of the process. Okay, does that make sense? So basically, if you have, when you look at the bottleneck step, okay, that is where all the arrows are coming in, that is where maybe your significant delays are happening. Okay, and then if you have a lot of if you have one step where a lot of arrows are going out of, that could be one of your most critical steps in the whole process or in your whole in your organization. Okay, so it might be worth your while to spend a lot of time thinking about improvement in that particular step. Okay, so that is an interrelationship diagram. Then you have a matrix diagram. Again, a matrix diagram is also it's like a project management tool when you want stuff to be done, or when you want to look at the relationship between different actions and different people who are supposed to carry out those actions. Okay, so you have, in this particular example, you can look at all the different actions and you can look at all the different employees or the staff who are supposed to carry out those actions, and based on the symbols that are used, you also know what kind of action is required of them. Okay, so here the legend that we have used is responsible, technical support, resource allocation, process management, etc. You could also create a different legend. Okay, you could probably have a legend that says very important, important, or nice to have, not so important, etc. Okay, so that'll as a decision maker, as a leader, when I look at it, it'll tell me which steps are more important and who's involved in carrying out those important steps, etc. Okay, so that is a matrix diagram. Okay, now we've briefly touched upon the PDSA earlier in this webinar. Now let me just introduce the model for improvement for you. Now, model for improvement is the one that is extensively popularized by the IHI, and it consists of 3 questions followed by the PDSA cycle. Okay, now each of these, it's a very simple looking model, but there is a lot of wisdom and a lot of detail in this particular model. Now let me explain that to you. So it begins with the question, what are we trying to accomplish? Okay, here you set your aim statement, okay, for your improvement project. Now again, going back to the example that we discussed in our previous webinar. Okay, let's say I'm trying to improve pneumococcal vaccination rates for patients who come into my clinic. Okay, what are we trying to accomplish? Improve pneumococcal vaccination rates for all patients who come into my clinic by let's say December 2019. Okay, how will we know that a change is an improvement? This is where I'm going to set measures in place. Okay, so I'm going to put some outcome measures and some process measures. Okay, so I'm going to look at, so what is my measure here? Percentage of patients who received pneumococcal vaccination. That's my outcome measure. Okay, and one of my process measures could be percentage of patients who received education about pneumococcal vaccination. Okay, when I measure these things, when I look at these metrics, I will know if any change I make has resulted in an improvement or not. The third question is, what change can we make that will result in an improvement? So this is where I come up with change ideas. I look at all different kinds of interventions or ideas that I can test in order to create that improvement. Okay, so you have an aim, you have measures, and you have change ideas. Those are the first 3 questions. And once you have those change ideas, you feed it into the circle called the plan, do, study, act. Okay, so let's say I have an idea that I should give educational pamphlets to all the patients who come into my system. Okay, so what I'm going to do is now I have to go about implementing that and testing that change idea. So I'll create a plan about how I'm going to give out those educational brochures. Then I will decide that, okay, starting next week for the in one particular clinic, I'm going to give out these brochures to the patients and explain it to see if that has made any difference in their awareness or not. Okay, so I plan for it, I do the change, then I study it. I will see, okay, how well did that process go? Did it create an increase in the awareness of the patients or not? Okay, what was their response? How well did it work? Is it feasible? Is it doable? Right, that's my study part. And based on the results that I get out of my study, whatever inferences I draw, I'm going to create my next set of actions. Okay, so that is the PDSA cycle. The three questions and the PDSA cycle together form the model for improvement. Does that make sense? Okay. Is my audio okay? Are you all able to hear me? Yes. Okay. Okay. We'll just quickly take a 2-minute break. I know it's been more than an hour since we started, so we'll just take a quick 2-minute break so that you all can just stretch, and we'll come back. All right. All right, everyone back? All right. Okay, so Sadia says, before this presentation, I always found this chapter difficult and challenging, but today it seems easy for me to understand the concepts. Thank you. You're most welcome, Sadia. That's my job. Um, all right, so let me just, I think I missed a question here. Okay, Sarah says, kindly elaborate the difference between activity network diagram and interrelationship diagram. So basically, interrelationship diagram, as the name suggests, shows you the relationship between different components of your system. Okay. Now, activity network diagram, on the other hand, is more similar to a process map. Okay, for any particular project, and this is actually a project management tool. So for any particular project, if you were to lay out the steps, step 1, 2, 3, 4, 5, 6, etc. Okay, you would put that in an activity network diagram, and what that allows you to do is it allows you to identify what is the quickest and the shortest way to go from A to Z, okay, to go from start to end. Okay, so activity network diagram is more similar, you could say, to a process map, not to the interrelationship diagram. Okay, does that make sense? All right, so we've talked about interrelationship diagram, matrix diagram, PDSA. Okay, now after PDSA, let's talk about prioritization matrix. Again, prioritization matrix is a process or a project management tool, and you would it basically allows you, as the name suggests, to prioritize your actions. Okay, when you have identified a bunch of issues, let's say using brainstorming and a nominal group technique and a multi-voting, you identify a bunch of issues, then you can use some objective criteria to prioritize those issues, and then you can identify what are the criteria you want to use to prioritize. Okay, and so that's why, again, let's say you have identified 5 different, based on your multi-voting. Okay, let's go back. Let's take one step back. Let's say from brainstorming you come up with 50 different ideas. Okay, then you use multi-voting to narrow that list down to 5. Okay, you've identified 5 different issues. Now you need to decide which of these 5 ideas you will be doing first and which one you'll be doing second, third, and so forth. Okay, how do you do that? Now, to do that, you could use a prioritization matrix, and what you will do is you could identify what are the criteria you need to use to reach that decision. So for example, one of your criteria could be resources available. Okay, or the number of resources this particular idea will consume. The second one could be the ease of implementation of this idea. The third one could be the buy-in that you can expect from your leadership. Okay, I'm just giving some examples, I'm just thinking out loud. So what you could do is then you could give some weightage to each of these criteria, and you could assign numbers to it, and then based on those numbers you could decide which of those factors have the greatest weightage, and which one has least, and the one that has the greatest weightage is the one that you would prioritize. All right, so that's a prioritization matrix. Okay, and okay, so when do you use a prioritization matrix? When you need to prioritize, as the name suggests, and when you need to narrow down your options, you need to reach a decision. Again, the role of the healthcare quality professional here is to suggest and advise leadership about these different kinds of tools that can be used when decisions need to be made. Okay, so you are sort of a facilitator who is going to walk the group or the team through these different tools. Okay, now let's come to what's known as a process decision program chart. What is this? This is usually a tool that is used along with, it's a tool that is used for root cause analysis, for RCA. Okay. Now, as part of your RCA or your root cause analysis, you're going to come up with an action plan, okay, to fix that particular patient safety issue. And so what you will do is you will identify the main goal, that is the top line, main goal that you want to achieve, and then what are the sub parts, that is the second line, Okay, the second row of steps that you need to do. So for chronic illness management program, you have patient self-management. What all do you need to do? You need to achieve patient self-management support, decision support, information system, delivery system redesign. These are all the different subcomponents. And then you further break down each of those steps into different sub-steps or sub-tasks that need to be done. And when you get to the last step, right, you can identify what all problems you might run into. So the second last level, those squares like inappropriate goals, backsliding, staff resistant to role changes, right? Those are the problems that you anticipate can lead to derailment of this particular step. Okay, and then what you do is on those thought bubble like things, right, you are going to identify some potential fixes that you can put in place to ensure that the derailment doesn't happen. Okay, so for inappropriate goals, what could you do? You provide nurse guidance and approval, or you could create a checklist of possible goals. Then you do for backsliding, to prevent backsliding, you could create some financial penalties, or you could have a buddy or a sponsor, etc. Right, so those thought bubbles are basically things that you could do to potentially solve those problems. Okay, and the X and the zeros that you see there, what are those? Okay, the X's are the ones that are actually very difficult to do. Okay, to introduce financial penalties would be a difficult step, or it's probably improbable. Okay, or to replace resistant staff, it might be difficult to do. So the X's are the ones that you are not going to select, and zeros are the ones that you're going to select to implement. Okay, so a process decision program chart is whenever you want to go ahead with implementation of a program, go ahead with implementation of an idea, you break down that idea into several implementable tasks and subtasks. And when you get to the last level of subtasks, you identify what are all the potential problems that could occur. And then you identify some steps that you could take to prevent that step from going wrong. Okay, that's a process decision program chart. Okay. So let's also talk now, since we have touched upon root cause analysis, let's talk about the difference between root cause analysis and HFMEA. Okay, HFMEA stands for Healthcare Failure Modes and Effects Analysis. Healthcare Failure Modes and Effects Analysis. Anyone here who's involved in HFMEA or RCA? Okay, so some of you have experience with RCA. It looks like most of you have more experience with RCA. Okay, so Natasha says more with RCA than HFMEA, but familiar and use both. Okay, great. So what the main I've actually placed both of them side by side so that we can compare both of them, right? So HFME is a proactive tool. Okay, this is where you identify something that is of critical importance to your organization or to your department, and you want to prevent something. You want to prevent something from going wrong. Okay, and so you're putting some measures and safeguards in place. That is HFMEA. It's a proactive tool to prevent errors or to prevent patient safety problems. Whereas root cause analysis is a reactive tool. After something has gone wrong, you go back and try to understand why it went wrong. Okay, so in HFMEA, what you do is you identify all the different potential modes of failure. You brainstorm about everything that can go wrong in a process, potentially go wrong in a process. Okay, and in RCA, what you do is you go back and again brainstorm everything that could have potentially gone wrong in this process. Okay, so you use a fishbone diagram, a cause and effect diagram, that is, to brainstorm all those different reasons. Okay, and in HFMEA, what you do is you assign numbers, you assign numerical values to that particular failure mode. So you identify a failure mode and you break it down into several sub steps. Okay, and then you look at three different variables. You look at three different factors. You look at severity, detectability, and occurrence probability. Okay, so what basically what you're doing is you're asking the question, if this particular step were to go wrong, how severe would it be? Okay, how severely would it impact patient safety? Second question is, if this goes wrong, how easily would it be detected? Okay, so that is your detectability factor. And the third question is, how likely is it that this step will go wrong, or what is the occurrence probability of that step? So what you do is, for any particular thing that you're trying to perform an HFMEA on, you will identify all the different failure modes, and you will assign these numbers, the severity, detectability, and occurrence probability numbers for each of these failure modes. And the one step that scores the highest will be the one that you will work on first. Okay, so that is the whole idea of detectability and occurrence probability in HFME. So a very popular question on the CPHQ is, they could give you a small scenario, and they could give you the severity, detectability, occurrence probability scores for the different steps in that particular process, and they'll say, which one do you want to act on first? And you choose the one that scores the highest. Got it? And yeah, so then what you do is, you do for HFMEA, you do that score, then you basically create a very high level flow diagram to look at the different steps in the process, and then you you make a management decision about whether you can eliminate that particular step, whether you need to control, put some control or mitigation steps in place if that goes wrong, or whether you need to accept it. There is nothing you can do to prevent that failure mode, and so you just need to accept its consequences if that were to happen. Okay, now HFME is a tool that came from the nuclear aircraft industry and the nuclear industry, and from aviation, etc. So these are industries that are obsessed with failure. Okay, because if something goes wrong, the effects could be cataclysmic, right? They could have disastrous consequences. And so what they do is, they're obsessed with what could go wrong and to prevent those things from going wrong. Okay, so if there is a failure mode that you can completely eliminate, you need to work to completely eliminate it. If there is something that you can control and mitigate, you need to do that. If there's something that you need to accept, you need to accept it. Okay, and then for root cause analysis, what you do is, once you've identified all the different causes that could have potentially gone wrong in this particular case, you go through several different steps, right? You go through what's known as the 5 whys, right? You go try to find out the root cause by asking the question why 5 times, right? You go and interview all your staff to find out why something happened, or to uncover any different kinds of factors, like organizational factors, system factors, social factors, work pattern factors, scheduling factors, all of those, to try to understand why the thing went wrong. Then you do an analysis of the root causes, and then finally you try to eliminate or mitigate or minimize those root causes. So you put action plans in place. When we do our next module, that is patient safety, we will talk about RCA more. Okay, so that's that. So Natasha says, we do mini RCAs for most of our incidents and of course high risk events. Exactly. Yeah. So generally organizations have various processes. So sometimes what happens is, before you do a full-fledged RCA, you can do sort of an interim RCA, or you can do an interim incident review, and then that can feed into the main RCA that you do. Right. Okay, another tool is what's known as the 6S. Now, this is a lean tool. It comes from lean, and it's basically, it's a tool that helps you to standardize your processes or your workplace. And it helps you to reduce waste. It helps you to minimize variation. And typically, you could think of this, a very common example is, let's say, how crash carts are put in place, or crash carts are arranged. Okay, so the first thing is, you sort your area. So whatever is needed is kept, whatever is not needed is thrown out. Then you set it in order. So you put it in a particular logical sequence. Again, imagine the crash cart, or imagine how a particular a ward or a room is set up. Okay, then what you do is you go through a shining process, which is cleaning, and you inspect that area to make sure that the organization stays in place. Then you standardize it. Okay, so standardizing meaning, let's say I'm working on a crash cart in area A, and then I'm supposed to work in, if I'm sent to work in area B, and there is a crash cart in area B, uh, I should, it should look the same to me. Okay, so it is standardized in both area A and in area B, so that even if I move from area to area, I know that the crash cart is going to look, have the same layout. It is going to be arranged in the same way, right? So that's why you're standardizing it. And then this is a cyclical process. You go back and forth to make sure that this is it is done on an ongoing fashion, ongoing manner. And then the key here is to find ways to sustain it. Okay, and all of this happens within the context of safety. Okay, so that is the success model. It's a lean model. It is made to eliminate waste and to standardize your workflow or your processes. This is a spaghetti diagram. A spaghetti diagram is actually a visual layout of a geographical area, and it actually tells you about how materials and people move from one area to the other in your work area. Okay, based on this, you can make some judgments about how much time is being wasted, how much effort is being wasted. If there is a better way, if there is a more efficient way, you can lay things out, etc. Okay, one common example, a very good example, is sometimes in the nurse station. This was an example, by the way, which one of my colleagues had given me, was that the nurses are working in the nurse station, and whenever a fax is sent, the fax machine is located at the far end of the ward, of the floor. And so what they have to do is, whenever they have to retrieve a fax, they have to go walk all the way across, okay, to the printer, which is kept in the other corner. They have to retrieve the fax, and then they have to come back to their workstation. So there is a lot of movement there, right? So a spaghetti diagram helps you to visualize this particular movement, so that you can then create a project or an initiative to optimize it. Then you have what's known as a CPHQ, or its invert, which is a corpus, which is basically, again, it's another way of looking at the process, where you're going to look at your internal and external suppliers, look at what their inputs are, what is the process for getting it done, what are the outputs, and who is the eventual customer. So let's say you're talking about sending lab samples from your unit to the lab. Okay, so the suppliers would be the nurses, and what are the inputs? It's the lab sample. What is the process of getting the lab sample from your unit to the lab? That is where you lay out your process. What is the output? And then finally, the output would be what the lab processes, the samples and the reports, and the final customers, let's say, are your patients. Okay, so that is a CPHQ diagram. So it is another tool that is used in lean process management. This is a tree diagram. A tree diagram is basically, it just maps out your process, and it looks like everything that can go wrong or everything that needs to be done, and then you make sure how you decide how it should be done. Okay, this is basically when you have a complicated task that you need to solve. Okay, and you also need to ensure that none of the steps are overlooked. Okay, and so that's where a tree diagram is used. Okay, so if you have an overall goal that needs to be broken down into several different steps, you need to work on those. It is kind of similar to the earlier tool that we saw, which is the process decision program chart. Okay, and so this is, I've given an example. So for example, we are looking at family quarrels during vacations. Now, what are the reasons that What are the reasons that there could be family quarrels? It could be because one spouse got sick, or both were tired, or they disagreed on what activities to do. Now, why would each of those happen? So you identify a third level of reasons, and then finally you put some mitigation plans in place, right? So didn't get immunized, so both of them should go and get immunized. If the hotel is in a noisy area, try to book at a secluded hotel. You want to, those kind of things. Okay, these are not very actually, a tree diagram and all are not very important tools, right? They are only used once in a while. For improvement, generally, a tree diagram is not very important. Natasha says, is it like a driver diagram? It is. It looks visually, in terms of its layout, it looks like a driver diagram, but a driver diagram is, basically, it's used to visualize what sort of change ideas you want to use in an improvement effort. Okay, so a driver diagram is basically done for that. But I agree with you. It is kind of similar to a driver diagram, but driver diagram is more improvement oriented. Okay. Yeah. Okay, now what is a value stream mapping? Value stream mapping is kind of similar to a process map, but here you're going to identify only the value added steps. So basically, if you were to think of the process map as the baseline or the reality, a value stream map is the future state or what you want your process to be. Okay, so if you were to eliminate all the non-value added and the waste steps from your process map, you would come to a value stream map. Okay, so value stream map is how would an ideal process look from start to end, right? So that's a value stream map. So that it's again a tool that is used to improve the flow of a process, and you reduce the waste in the process. Okay. Okay, now we are going to switch gears. We've talked about the tools for improvement. Now we're going to talk about some other concepts like teamwork for improvement. 10 competencies for effective interprofessional teams. That team needs to have a leader. It needs to have a set of values that people agree on and that provides guidance. There should be a team culture. There should be an atmosphere of trust within that team culture. They should ensure that there are appropriate processes and infrastructure in place for the project. There should the team provides quality patient focused services. There is adequate communication between different professional levels. There is adequate staffing for the kind of care that is required to be provided. And there should be processes in place to recruit the right competencies that are required for delivering on the mission and the vision. And you should promote role interdependence. This is where there is respect for different roles, for different competencies, for different kinds of experts, and for different disciplines. And there is a focus on personal development where people have the opportunities to develop their skills and their expertise and to move up the ladder. Okay, so these are 10 competencies of effective interprofessional teams. Again, these are straightforward, common sense kind of concepts. And if you get a question on it, there's no reason why you should not be able to answer them correctly. Okay, now let's talk a little bit about teams. I have dealt with this concept in detail on the CPHQ Essentials course. So I'm not going to spend a lot of time here. One favorite question of CPHQ, when do you use teams? Teams are used when you have a complex task. So what are the criteria that you'd use? You have to think about the complexity of the task you're trying to accomplish. The more complex the task, the better the role of a team. Okay, you look at interdependence of the task. Okay, so do you need different disciplines to talk to each other or work with each other, collaborate with each other? So that's when you would use teams. And then you look at the objectives that you're trying to accomplish. Okay, based on the objectives, you would decide if you need to use teams or not. What are some predictors of team success? 4 C's. Okay, cohesiveness of the team, communication amongst the team members, the presence of clear goals, and presence of clear roles. Okay, the 4 C's of team success. and some important team-based concepts that can be found in healthcare. One is team steps. Anyone here familiar with team steps? Anyone involved in it? Yes. Oh, Natasha again. So Natasha is very familiar with all these tools we're discussing here. So yes, so team steps is basically team strategies and tools to enhance performance and patient safety. It's actually an evidence-based system that is designed to improve communication and teamwork. Okay, and team members learn 4 primary skills. They learn about leadership, about communication, about situation monitoring, and mutual support. Okay, so that's the team steps model. Then you have the other kind of concept is the crew resource management concept. Okay, so there are training programs, and basically again this has come from the aviation industry, and the focus here is on developing a mindset of patient safety in the staff, and also this is a concept that is adopted by high reliability organizations. Okay, where you want the care process to be highly standardized and highly predictable and highly reliable and highly consistent. Okay, so CRM is based on high reliability, on the concept of high reliability. Then you have something known as a workout. So this is basically done by organizations that use Six Sigma or Lean Six Sigma, and a workout is basically where a group of team members, they work like a SWAT team, where they come together, they work for a short period of time, and they're working on one particular clearly defined challenge. Okay, so that's the concept of the workout. Just good ideas to just keep in mind. You could get a question or two. Question, actually not two, but just one question on this, any of these. Okay, important to remember the Tuckman's model. Tuckman's model for team development. There are 4 stages of teams: the forming stage, the storming stage, norming stage, and performing stage. Okay, now Tuckman basically posits that when teams come together, when members of a team come together, they go through these different stages. So the first stage is the forming stage, where team members get to know each other and they're trying to wrap their heads around what they're trying to accomplish, etc. And at this stage, you need a directive leader, a leader who actually takes on a directive role. Okay, from the forming stage, they then move to the storming stage, where some discord will start to come to the surface, where team members could disagree with each other. They feel that their roles and their goals are clashing with each other, etc. At this stage, the leader has to assume the role of a coach. Okay, they must coach in order to keep the team together, the leader must become a coach. Then if you go through that stage, then you will come to the norming stage, where the team is now slowly starting to come together. People are starting to enjoy working with each other. They are more aligned with the roles and the goals and the mission of the team. Okay, and so that's a norming stage, where now some results are starting to be produced by the team. Here, the role of the leader is to be a supporting leader. So basically, making it easy for the team to achieve their goals. Okay, once they finish that stage, they will come to a performing stage, where everybody in the team is aligned. They're all very clear about what their roles are, what their goals are, and they're all looking towards the same mission and the vision, and they're working well as a team. Okay, that's the performing stage, where then the results are accelerated. They're moving forward well, and they're a well-functioning team. At this point, the role of the leader is to sort of step back and let others take the credit, to share the success, to share the limelight, etc. Okay, now Tuckman says that different teams may move through these stages very quickly. Some of them will be moving very slowly. Sometimes some teams will be going through these stages, and they may actually fall back to one of the earlier stages. So a team could be moving through forming, storming, and norming, and then after they are in the norming stage, they could go back to the storming stage, etc. Okay, so these are the 4 stages in the Tuckman's model. So again, what kind of question can you expect on the Tuckman's model? They could give you a scenario, and they could ask you what stage the team is in. Okay, or they could give you a scenario and ask you, based on the stage that the team is in, what is the job of the leader. Okay, so those are the kind of questions you could expect. It's pretty straightforward. Okay, now steering committees, the use of steering committees for running quality programs in an organization. Okay, what do steering committees consist of? They are quality improvement teams consisting of cross-functional members. They could involve patients or their family members, okay, to get inputs from the community, from the customer. And their job is to sustain and facilitate process improvement initiatives. And they could involve, or they should involve, top leaders in the organization. So they are basically responsible for, as the name suggests, for steering the quality programs of the organization. We've talked about this a bit in the first module on organizational leadership. What are the responsibilities of the steering committee or the quality council? They lend legitimacy to the quality improvement initiatives of the organization. Okay, they help to maintain focus on the mission and the vision and the strategic priorities, quality priorities of the organization. They help to foster a sense of teamwork. They are responsible for providing resources to get this job done. And they also formulate policies within the organization related to quality and patient safety priorities. Right? Okay. Now, when you're running quality improvement programs, one of the jobs of the healthcare quality professional is to advise the leadership about providing the right kind of incentives for the staff and the employees to feel motivated to advance the mission of quality for the organization. Okay, in order to do that, it's important that you have an understanding about motivations and motivational theories. Okay, and this is again HR 101. And so let's just look at some of the theories, right? So you have four kinds of theories. You have need theories, you have expectancy theory, you have equity theory, and procedural justice. Okay, now what do need theories say? Need theories are of three, have been given by three main experts. Okay, first is Maslow. Maslow gave us the Maslow's hierarchy of needs, which basically says that human beings progress through different kinds of needs, from starting from basic to higher level needs. Okay, the first one is your survival need. Once you fulfill those survival needs, then you have safety or security needs. Once you fulfill that, you have social needs. And once you fulfill that, then you have some status needs, and finally you have self-actualization needs. Okay, so unless the lower level needs are not fulfilled, there is no point talking about the higher level needs. This is what Maslow's hierarchy of needs posits. Okay, then McClelland gave this theory that that there are three kinds of needs that people have. Well, they have achievement needs, they have power needs, and they have affiliation needs. So whatever you do for them has to fit into any of these needs, has to fulfill one of these needs. Then Herzberg gave the model that there are two kinds of there are two kinds of needs that people have, or there are two kinds of factors that motivate people to do something. Right? You have motivators and your hygiene factors. What that means is their motivators are those things that you get out of a job that, if present, they motivate you to do a good job, and if absent, they will actually deflate you. All right. Now, that is different from hygiene factors. What are hygiene factors? Hygiene factors just basically means that the presence of it is not enough to motivate you. If it is present, you may not be motivated, but if it is absent, you're certainly demotivated. Okay, so that's the difference between motivational factors and hygiene factors, as mentioned by Herzberg. Then you have what's known as an expectancy theory. Expectancy theory basically has two components to it. Okay, as a worker, think about yourself. You are making conscious decisions about what kind of behaviors to engage in and what kind of job to do. You have two basic questions in your mind. First question is, if I put in this do I have the skills to create this kind of effort? And if I put in this kind of effort, will I get some rewards out of it? Okay, so am I able to do this? And if I do, should I do this? Okay, so can I do this and should I do this? So can I do this means, do I have the skills necessary to do it? And should I do this means, if I do it, are there any rewards at the end of it? Okay, so when you're designing some motivational programs or incentive programs in your organization, these are things you need to keep in mind. The third thing is equity theory. Equity theory basically says that every employee expects fairness in their workplace. Okay, so even when they don't get the same kind of rewards as their colleagues might, they will they want to see what are the criteria that are being used to judge their performance. Is there a fair set of criteria that judges their performance, right? Or is it like some people are being favored over others without any, with some arbitrary criteria? Okay, so that is the equity theory. Okay, and then finally you have what's known as a procedural justice. Procedural justice basically says that, again, it's a concept of fairness. It says that I can live with certain decisions even if I don't like them, provided I feel that a fair process was followed, that I got a fair hearing or a fair process was followed by the organization. So that is a concept of procedural justice. Okay, so just remember the statements that I made when I'm talking about these theories, because those statements are going to help you to answer the questions. That's all you need to remember, because generally what you will get is, you might get a recall question. So they might give you a statement and say, okay, which of these theories, which theory is this statement talking about? Expectancy, equity, justice, etc. Or they could give you a scenario and say, what is the right answer? So you have to decide, that there should be fairness, there should be equity, there can be expectancy theory, or it could be related to one of the needs theories. Okay, so those are the kind of questions you can expect. Again, these are very common sense kind of questions. Okay, second thing, what determines retention and performance of employees? There are 12 factors that were identified by the Gallup organization, about 12 factors that are critical to retention and performance of employees. So, Gallup actually conducts these surveys in organizations, and their surveys ask these very same questions to employees. I don't know if you've been through one of the Gallup surveys. I have been, certainly in some of the organizations that I've worked with. So they'll know, like, do I know what is expected of me at work? Do I have all the resources necessary to do my work well? Do I have the opportunity to do what I do best? Okay, did I receive recognition or praise for my work? Does someone at my workplace care for me as a person? Does someone encourage me? Are my opinions valued? Am I aligned with the mission or purpose of the organization? Do I have a best friend at work? What else? Is somebody helping me with my progress of my personal development? Okay, do I have enough opportunities to learn and grow in this organization? So those are the different critical factors, okay, that determine retention and performance of employees. Then also healthcare quality professionals may be involved in creating reward and recognition systems in the organizations. And how do you create these incentive systems in the organizations? You could, this is, why are you doing this? Basically to keep up employee motivation and to make sure that people are contributing to quality and patient safety. So you determine what sort of behaviors you need to reward. And that goes back to the question of what are your values, what is your mission, what is your vision. Okay, you establish some criteria for it, you establish a budget for it, and determine who is the process owner for managing the recognition and rewards. Okay, then what are the procedures and features for those recognitions and rewards? And then also make sure that you have a system, you have a mechanism in place to get feedback from employees about what they think about this recognition and reward system. And you keep on tweaking and improving that program based on the feedback that you receive. Okay, and the key concept here for you to remember, if you get any question on this, is organizations must identify what their mission and vision is. They must identify what their values are, and then The job of the leadership and of healthcare quality professionals is to reward the right behavior. Okay, the more you reward the right behavior, the more that behavior gets replicated. Okay, it's like raising children, right? If you reward the right behavior, they will go on doing those right behaviors and the bad behaviors will fall off. That is the same concept here. Okay, and then you share your success stories in quality and patient safety. That is another incentive. So you create different kinds of forums in your organization for sharing these success stories. Okay, perhaps you could have a monthly meeting or a quarterly meeting, or you could have an annual forum where you have different storyboards for process improvement, where people can showcase the good work that they've done in their units, and they can show the tangible improvements that they've created. Perhaps you could send them to conferences, and help them to share those stories, help them to publish papers that show their improvement efforts, etc. Right. So all this is the work of leadership to create the right environment so that all this can be fostered. Okay. Okay, so Natasha says, I don't see the slide on Gallup. Natasha, that's because there is no slide. I was just talking about it based on the second point that you see here, what determines retention and performance of employees. I've just mentioned the main points there. The reason I did not add it as a slide is because it's something that is in the public domain. That's why I did not add it here. But basically, those are the critical factors that actually determine employee retention and performance. Okay, then the last concept is about recognition and quality awards. As a quality professional, you are required to apply for external quality awards, and also for creating the situation and the routine for giving internal quality awards. Okay, so basically, how do you evaluate the readiness of your organization, whether your organization is ready for these awards? First thing is your leadership commitment. Okay, that is the main thing, and then you identify. Second, you identify what sort of award you are applying for. Okay, then identify what are the requirements of that award. Remember, there are different kinds of awards, right? You have this Baldrige. The most popularly known one is the Baldrige Performance Excellence Award. Then you have the Deming Prize, that is in Japan. Then you have the Magnet Recognition Program. I'm sure many of you must have seen. So that is like a nursing-oriented program, right? The Magnet Recognition Award. Then you have the Healthcare Quality Recognition Award, which is given by the NAHQ. So these are the different kinds of quality awards, and basically these awards are to demonstrate that you fulfill a certain set of criteria for excellence in quality and patient safety. Okay, so first thing is there should be some commitment, some leadership, and some ownership for applying for these awards and for keeping up the standards. Okay, then and these standards must be kept up in daily practice. Then as a quality professional, you will identify what is the quality award that you're going to apply to, what are the criteria that you need to fulfill. Then you determine the eligibility of the organization, whether you are eligible to apply for that award or not. Then you create a team, a task force that will be working on this award application. Then you perform a gap analysis. You do a self-assessment to make sure that you are meeting all these standards. It's very similar to the accreditation process, right? The CMS accreditation or the Joint Commission accreditation. It's very similar to that process. So you do a self-assessment or a gap analysis and make sure that you are closing all those gaps, that you meet all these criteria, and you identify the strengths or evidence of compliance to each of these criteria, and see if there are any opportunities for improvement. And once you do that, you create a course of action, you create an action plan to address those gaps, to meet those standards. And once you do that, you complete your application and you submit your application. After that, the awards committee will come for a site inspection. They will visit your site and they will look at your evidence that you're meeting all these standards. And then if you get that award, rate the success and make sure that you maintain that award from year to year. Okay. That brings us to the end of module on performance and process improvement. The rest of the materials that you need for this module are um, potential scores that I'll be sharing with you. That's it. Do you have any parting thoughts, any comments? So May is asking, can we download the health analytics webinar we had before the start of the course? Yes, May, I'll be making that available to you. I will put that in the folder so that you can review it again. Any other questions? Sure. So yes, I'll be giving the link to everybody. So don't worry about it. You will all get the a link to the first webinar that we had on data. Okay, and so if there is no other question, so just a word, a suggestion. Whatever questions about or any doubt that you may have, please make a note of it. And on our Q&A call that we'll be having in about a couple of weeks from now, if you have those questions, just send them by email to me in advance, and we will have a discussion on it on our live session. Okay, so our next webinar is going to be on Wednesday, and we're going to talk about patient safety. Okay, so that's it for today. So good afternoon and good night to you all, and I will talk to you on Wednesday. Thank you very much. Thank you and take care. Bye bye now.